Yeah, so I think unfortunately we've had, sort of another setback. The original agent, was APR-246 or Eprenetapopt, which is the only kind of frontline high-risk P53-mutated MDS trial. That trial kind of narrowly missed its bar, although I will be presenting some, updated data at ASCO. I'd love for that agent to be resurrected and potentially a different combination therapy. The next agent is really Magrolimab, which did run a P53-mutant AML-specific trial and has dosed quite a bit of patients in the MDS setting as well. At EHA meeting, these data will be updated, but unfortunately, again, this subset of patients did not have improved outcomes with that. So right now we're a little bit at a crossroads for kind of what the frontline high-risk paradigm is. I think even if VERONA is positive and we do have Venetoclax approval, that has not appeared to improve outcomes. The true CR rates with Venetoclax have not been different. I think the one other agent that is in phase 3, which is the Tamibarotene agent, for RARA overexpressing, it's unclear how P53 may impact whether or not somebody is RARA over or underexpressed. It seems to be somewhat agnostic to molecular subtypes, but I think we need to have data. How does the P53 mutant group, go forward? I do think kind of novel combinations and still potentially thinking about novel IO strategies in combination with HMA trials are still warrant some excitement. There are several newer anti-CD47 agents, somewhat focusing on P53. There's an agent with Shattuck Labs that's now entering a randomized phase 2 trial, not specific for P53, but I think that will be a key subgroup that we look at. There's also Leukemia, which has had some exciting data out of China, and that trial is also sort of entered a randomized dosing optimization phase in the US as well. But I think right now the chalkboard is clean and we can really come up with hopefully new concepts, likely non-cytotoxic strategies to try and improve this group. The one other trial that I mentioned is there's a metronomic dosing. This has been led by Amit Verma and Montefiore, where there's a weekly dosing that potentially is having at least just as good of responses in the P53 subset and maybe less toxicity. So although I don't think it will be majorly changing the bar, maybe it could improve safety in a subset of patients.